In this talk, I'm going to go through our imaging protocols. I'm going to take you through how I report SPECT-CTs of the knee, and I'm going to explain to you some common pathology that you might expect to find when we're looking at knee SPECT-CT scans. So let's start off with a total knee replacement. As you can see on the left, there is a femoral component and a tibial component, and sometimes the patella has been resurfaced and there's a patella component as well. Don't forget, between the femoral and the tibial component, there is usually a plastic spacer which acts as the meniscus does in the normal knee. Sometimes this has a keel in patients who have a cruciate replacing knee replacement and acts as a stabilizing function for the knee. This is our standard procedure for imaging the knees. We start off with a dynamic anterior and posterior image, followed by a fast blood pool SPECT-CT acquisition. This is a 7-minute SPECT acquisition and a low-dose CT. After that, we perform a delayed whole-body planar image at around about 3 hours, and we look for sites of referred pain, such as in the spine or in the hips. We also then perform SPECT-CT of the knees. This is a 15-minute SPECT acquisition and a diagnostic quality CT. When we perform CT of the knees at a diagnostic quality, we use a high MAS, in this case 200 MAS, and we're using a Siemens camera, so we have care dose modulation switched on. We also use a slice thickness of 1.25 millimeters and an overlapping pitch of 0.65. We also use an extended Hounsfield scale if the patient has a knee replacement, and a higher KV than normal, just to overcome the noise from the metalwork. We also perform a small field of view reconstruction of the symptomatic painful knee. This slide explains why extended Hounsfield scales are useful. If you don't have access to metal artifact reduction software, then I urge you to switch on the extended Hounsfield scale. This extends the maximum Hounsfield units that can be displayed from 4,000 to 40,000. So the image on the right is on the extended Hounsfield scale, and you can see how there's much less streak artifact from the metalwork. We also increase the slice thickness in the reconstructions to 5 millimeters when we're displaying. That also reduces the noise and makes it easier to reduce some of the artifact from the metalwork. When we are performing SPECT-CT of the knees, it is helpful to assess the component position. We do this using long-length topograms, and this is based on the traditional technique of using long-length plain films. It's an alternative to the Perth knee CT protocol, which is a higher dose investigation. By using an anterior and a lateral topogram, we can assess the varus and valgus position and femoral angulation and posterior tibial slope. It's helpful to measure the posterior tibial slope. Essentially, the tibial component should have a slight posterior tilt relative to the tibial shaft. If you have an anterior slope or a 0-degree slope, then this can lead to impingement as the knee is flexed. The other things that can be assessed on the CT component of the SPECT-CT are the rotational alignment of the femoral and tibial components. I won't go into too much detail other than to say we use Berger's method for measuring the rotational alignment. On the tibial component, we combine a slice through the tibial tray with a slice through the tibial tuberosity and measure the component rotation relative to the tibial tuberosity. The femoral component rotation is measured from an axis through the medial sulcus to the lateral epicondyle, relative to the posterior aspects of the femoral component. We are often asked whether it's still worthwhile doing dynamic and blood pool imaging, and I think this example shows us why. The first thing I'd look at when I look at the bone SPECT-CT scan is I look at the dynamic and blood pool imaging. We can see on the dynamic and blood pool phase images there is some activity in the soft tissues around the knee. On the CT component we can see there's a small joint effusion. This would suggest there's a synovitis. Again, this is where blood pool phase SPECT-CT is very helpful. We can see on the blood pool phase SPECT-CT that there is increased tracer uptake within the synovial capsule. Okay. Again, indicating that this is a synovitis, and the increased activity that we're seeing is not related to the prosthesis itself directly and is not within the bone but within the soft tissues and within the synovial capsule. So in order to diagnose synovitis, we would like to see increased activity on the dynamic and blood pool phases, which conform to the capsule of the joint. We can sometimes see thickened joint capsule and a joint effusion on the CT. There are several causes for synovitis after a knee replacement. Obviously, the most concerning is infection, but we often see it associated with polyethylene wear and ligament imbalance. Finally, you can see arthrofibrosis, which is a chronic inflammatory response within the knee, which can cause a chronic synovitis. A common pathology that we are asked to look for when we're assessing knee replacements is aseptic loosening. This is essentially mechanical movement of the prosthesis. It is multifactorial, and it's really helpful to compare the component position of the prosthesis with baseline plain films. If you see migration of the prosthesis on serial imaging, then you've got your answer. There is loosening. There are several reasons why you might have loosening of the prosthesis. First of all, there may be poor positioning, so the prosthesis may have been put in incorrectly in the first place. Second of all, there can be material failure, so either the metalwork fractures, which is very rare, or more commonly there is a fracture of the polyethylene components of the prosthesis. Finally, you can have a reaction with the bone resulting in osteolysis and migration of the prosthesis. And this is an inflammatory response. SPECT-CT is very useful in differentiating aseptic loosening from infection. It has a high sensitivity and specificity for loosening. And one thing that's very helpful is to look for focal uptake in the sites of maximal stress. For instance, in the tibial component, you will often see focal increased uptake at the tip of the tibial stem and within the contralateral tibial tray. In the femoral component, you will see increased uptake in the posterior condyles, and some authors have reported increased uptake in the lateral femoral component as a specific indicator of loosening. Finally, don't forget that there is a patellar component which can also be loose. And if you see increased uptake associated with an irregular periprosthetic lucency around the patellar component, this also suggests loosening of this component. So the hallmarks of loosening are component migration. So if you see movement of the prosthesis on serial imaging, you will see increased flow and hyperemia on dynamic and blood pool phase imaging. It's more common within the tibial component, and uptake can be asymmetrical within the tibial component. More commonly, it's around the tibial tray, medial tibial tray. Look for an irregular lucency around the prosthesis, more than 2 millimeters in distance. And Usually with loosening, you won't see new bone formation, which is a hallmark feature for infection. So these are examples of aseptic loosening. You can see that there is an irregular lucency beneath the medial tibial tray, and there is associated increased tracer uptake. Loosening of the patellofemoral component can occur if there's either a fracture of the patellofemoral component, infection, or mechanical overstressing. So in this case, the patient had a flexed femoral component, which was picked up on the lateral topogram. This leads to overstressing of the patellofemoral joint and early loosening of the patellar component. And you can see on this image there is some increased uptake with an irregular lucency of the bone prosthesis interface. Particle disease is a condition where there is an inflammatory response within the bone to some component of the prosthesis. It leads to osteolysis at the bone prosthesis interface and is due to macrophages and multinucleated giant cells releasing cytokines as a response to that component of the prosthesis. Because of the osteolysis, they can lead to loosening of the prosthesis. You will see typical scallop-shaped margins to the osteolytic parts of the bone. Usually, uptake is only slightly increased, if at all, around the prosthesis with particle disease. Increased uptake in the patella following a joint replacement, even when there hasn't been resurfacing, is quite common. It can indicate patellofemoral joint pathology, but is not always specific. Increased uptake can represent progression of patellofemoral joint degeneration. It could indicate patellar maltracking, and it can be a result of patellar overstressing due to a high or low-lying patella or abnormal femoral component positioning. Focal increased uptake in the patella is suggestive of patellofemoral degeneration, but diffuse uptake is less specific. First thing I do when I assess a knee replacement and I see increased uptake in the patella is decide whether I think the patella has been resurfaced or not. Sometimes it's tricky because of the artifact from the adjacent femoral component. It's sometimes helpful to look for the peg holes within the patella and then determine if you're seeing focal uptake or diffuse uptake. Then assess the position of the patella. Is it low-lying? Is it high-lying? Is it tilted? Then check for rotation and flexion of the femoral component, which can predispose to patellofemoral degeneration and patellar maltracking. Focal increased uptake in the patella, in an unresurfaced patella, can indicate patellofemoral degeneration, and this can sometimes be the source of the pain if it is in the anterior knee. In this example, there is evidence of patellar maltracking with tilting of the patella, obvious loss of joint space along the lateral facet, and focal increased uptake with subarticular cysts. In a patient who hasn't had a knee replacement, if you're looking and assessing for patellofemoral joint degeneration, it can be useful to use a classification system for the trochlea to assess for trochlear dysplasia. Commonly used one is the de Jong classification. So type A would be a shallow sulcus of the trochlea. Type B might be a flat sulcus. Type C would be a convexity of the trochlea. And a type D results in a cliff edge bump on the edge of the trochlea. You can also measure things like the lateral trochlear inclination, which should be greater than 11 degrees. If it's less than 11 degrees, might indicate patellar maltracking or predisposition to patellar maltracking. We can also assess things like the sulcus angle, which is usually less than 138 degrees. Finally, we can assess the tibial tuberosity to trochlear groove distance, which should be less than 15 millimeters. If it is greater than 15 millimeters, this can sometimes indicate that the extensor mechanism of the knee is extending a little bit too much at an angle, and as the knee is extended, the patella may be pulled laterally. Infection of knee replacements is the most serious complication. Thankfully, they are rare in primary knee replacements, only up to 2.5%, but they occur in up to 20% of revision knee replacements. The difficulty is that a third of infections occur within the first 3 months, a third occur in the first year, and the final third occur after 1 year. So the difficulty we have when imaging knee replacements for infection is that we will often see an inflammatory reaction which occurs both in infection and aseptic loosening. The difference is that neutrophils are present in the infection, not in aseptic loosening. The other difficulty we have is the normal pattern of uptake in the knee is very variable. Given that up to a third of infection occurs in the first year, when we know that uptake is very variable in the knee during that time, it makes it very difficult to be specific about diagnosing infection. However, bone scans, even in that first year, are useful because a negative bone scan has a high negative predictive value. So we will still do a knee SPECT-CT in a patient less than a year or less than 2 years from surgery because we know that a negative scan is helpful. This is an example on planar imaging of a infected knee prosthesis. You can see there's increased vascularity on the blood pool phase and on the dynamic images. On SPECT-CT, we have a lot more detail. We can see there's diffuse uptake around the prosthesis, but we can also look for things like intraosseous abscesses, cloaca, which are holes in the bone, and periosteal reactions, aggressive, irregular, fluffy periosteal reactions. To diagnose infection of a prosthesis, we would like to see increased uptake on the dynamic and blood pool phase imaging, which suggests inflammation. We would see diffuse uptake around the prosthesis, periosteal reaction. Sometimes we may see soft tissue edema or a soft tissue abscess, and we may be associated with a joint effusion. Unicompartmental knee prostheses are not commonly performed. However, we do often perform SPECT-CTs on these patients, and they can be tricky to interpret. Often it's the medial compartment that is replaced, and the reason for performing a unicompartmental knee replacement is that the recovery and the rehabilitation is much quicker for a unicompartmental knee replacement compared to a total knee replacement. However, the complications are similar. One difference is that we will often see impingement around the prosthesis in the intercondylar eminences with a unicompartmental knee replacement, as in this case here. SPECT-CT can be useful in assessing for osteochondral defects in patients who haven't had knee replacements. Studies have shown that there's a high correlation with focal uptake and full thickness cartilage loss and bone marrow edema on MRI. But bone uptake may actually be more sensitive than the edema on MRI for bone injury. So if you're seeing focal increased uptake in the knee, look for any subtle cortical lucencies which would suggest cortical bone loss. And this is something that needs to be reported. It isn't simply osteoarthritis, this is osteochondral defect. There may be a surgical management or arthroscopic management for this. So I hope I've been able to explain to you how SPECT-CT adds an additional dimension to assessing the total knee prosthesis. I would urge you to optimize your CT, add in extended Hounsfield units, small field of view imaging. I would suggest you look at how you can measure the prosthetic component position and also look at measuring patellar maltracking with your SPECT-CT. Thanks very much for your attention. If you'd like to contact me to discuss anything aspect of SPECT-CT further, or you have any questions, please contact me on my email shown here.